So good morning to everyone. Thank you for coming this early. I'm gonna start with our case of the day. I hope you find it like uh, very useful and interesting. And here's like the link for the questions. We're going to do like a poll everywhere questions to the presentation, and we will have later on also the QR for the questions. So our patient today is a 49-year-old female that presents to the emergency department with palpitations. She reports the palpitation began 1 month ago, mostly after lunch or dinner. They were short and self-resolved. However, in this time, the palpitations were persistent and associated with shortness of breath, so she went to the emergency department. She denied other symptoms. She didn't have chest pain, dizziness, neither syndrome. She was able to perform activities of the daily living without difficulty, and there was no significant prior cardiovascular history. There was no drug allergies. Regarding alcohol use, she reported 2 or 3 beers daily. She was a current smoker, and she also used cannabis daily. In terms of the physical exploration, she was the normal temperature, hemodynamically stable, and without acute distress, and the rest of the physical exploration was unremarkable. We show you here the ECG that shows a normal sinus rhythm, 60 beats per minute, and maybe like you're already looking at those negative T waves that we can see in the inferior and precordial leads. And in the notes from the emergency department, like in the telemetry, they reported like frequent PVCs that they were not shown on the ECGs. We have also the chest X-ray, which was normal, no pulmonary findings, normal pulmonary vascularity, and the cardio mediastinal silhouette is also normal. The lab work was also normal, the troponin was negative, and because of the symptoms and the abnormal ECG findings in a young lady, she was admitted for workup and telemetry, and a TTE was ordered. So without further delay, we'll see the echo findings.
Excellent. Yes, and Dr. Agarwal, we're going to lean on you a bit here at the beginning. If you can walk us through this echo, please.
So parasternal long-axis images with and without color, maybe some minimal basal septal thickening so far. On the color Doppler images towards the apex, you can start seeing mass or some sort of a density that seems to be coming in and out, incompletely visualized. So when we readjust our plaques views, go a little bit off axis, we are able to see this echogenicity that is present at the LV apex. Looks pretty hyperechoic for now, or maybe some hypoechoic spots in the middle in the center. But so far, that's what we are seeing. Next one. So again, trying to show that mass slightly better, and it is being measured out. It measures out to about 4.2 by 2.5 centimeters, more towards the LV apex. That's what it looks like. The RV apex RVOT also does not appear to be completely free. And when you look at this image, you see that it probably is either compressing or deforming the septum for sure. Whether it is inside the septum, outside the septum is a little bit difficult to say just based on these images, but you can definitely see that it is also sort of deforming the RV apical cavity. So that's what we have so far. So towards the septum, mid to apex, involving the apex, not really sure if it is invading the myocardium or not, but this mixed echogenicity features are there. On this view, I think the relevant feature in such cases that you are beginning to see triple pericardial effusion, which you did not appreciate before. And again, this will become more important as we discuss more about this. So now these are images with echo contrast. You have your four-chamber, and this looks like a modified subcostal kind of a view that we are seeing. And there is some contrast that definitely goes into the mass. So it's not an avascular structure. So that rules are pretty much thrombus or anything of that sort, because that is sort of a classical location for that. The other thing to keep in mind is that the wall motion over there is not like completely, it's not an akinetic part of the left ventricle. So the chances that this can be just be an isolated thrombus over there with not any kinetic chamber is less wall, but again, something to keep in mind.
Okay, great review of that. So, Dr. El-Hamamzi, I think oftentimes our tendency in cardiology, right, is to get 3 or 4 imaging studies, get all of our ducks in the row, and then we'll call this right. But I'm kind of curious at this early stage for your perspective, what are the questions just on this echo, just knowing 49-year-old palpitations, 2 inversions, we don't know what we're dealing with. How are you seeing this case? What questions are you starting to ask? What kind of information do you want?
Thanks. Well, luckily these are rare findings because but just seeing the images, the questions we'd be asking is the relationship of this with the other structures in the heart, with the muscle, with the vessels, with the subvalvular apparatus, just to try and delineate a little bit. Is this very circumscribed, or is this very invasive? Is it outside in the pericardium? Is it just contained in the muscle? How big is it? What's the relationship with any of the coronary arteries? Just with always a thought of, if we have to resect this mass, how possible is it? How much can we preserve all the while being complete? But obviously, the first question will be: is this something that is malignant and even requires anything done, or is this something that is benign, which can, very well be the case, and where we can just, watchfully or actively surveil?
Okay, so we go with the first question. You can find the QR here. What is your differential diagnosis? I know it's early, but we are not giving any options for this question. So please go with your brainstorm from the differential diagnosis, wherever you think this could be. I'm going to activate now. Once you have all of them here. Okay, so you can start answering the problem.
Getting some great answers coming in here. Some benign, some malignant tumors, also thrombus, Loeffler's, different types of tumors. As these are coming in, let me turn it over to the panel. What are your thoughts? What's your differential on this? Can I start with you, Dr. Kassan?
So this could be benign or malignant cardiac neoplasm. It's very difficult to say just based on the echocardiogram, but it looks like some kind of cardiac neoplasm because it's not, it's within the wall, not looking like it's within the ventricular cavity.
How about Dr. Agarwal?
Yeah, pretty much echoing the thoughts over here. It looks like it's some sort of a tumor. It does not have the characteristics of thrombus for now. Primary, secondary, what else may be going on is still on the differential diagnosis. One of the things that you have to keep in mind again is as you're thinking about this at an early stage, as Dr. El-Hamamzi said, was sort of relationship with the surrounding structures, and just the fact that there was not a significant invagination of the pericardium, not significant pericardial effusion, makes me think that even if it is a tumor, if you're thinking of that, then it's probably not very aggressive just given the size of it. But can it be primary, secondary metastasis? Everything is on the differential for now from that perspective, just those images. But thrombus is probably low on the differential for me for now. Great.
So, yeah, a lot of people said already like tumor, obviously thrombus, myxomas, like the very common benign masses, and other were more on the negative side with sarcoma or metastases, but great answers. Even like some other things as Loeffler's one person answered.
I love the echinococcus granulosus.
Okay, so
Dr. Niebart on the call, maybe?
So that was a great exercise. Thank you so much, everyone. And when we go into the differential diagnosis of a mass, it's kind of difficult, and we have to try to organize our way of thinking. So there's a lot of state-of-art reviews on this topic that help us organize our workup. So the first thing we should do is consider if this could be a normal variant. In this case, it doesn't look like it unless we are committing like a pitfall, like a foreshortening, and we have like a weird image. But in other cases, for example, in the atria, like the lipomatous hypertrophy of the intervertebral septum, or like the Coumadin ridge, or the pisa terminalis, we have to make sure that sometimes there are some pictures that we can see on the echo that could look like tumors, and then we can like find out the normal variants. After that, because of the frequency, we also have to think, as we have been doing here, this could be a thrombus or vegetation. In this case, because of the location and the clinical context, like is this a thrombus? We already discussed about that. As also the panelists were saying, like always thinking in tumors, like if this is a secondary tumor, this is metastatic disease. And in case if it's a primary cardiac tumor, always thinking first the benign cardiac tumors, because they're far more frequent than the malignant primary tumors. With the most common of the benign is the myxoma, but the bad side of that is like the most common tumor is the metastatic disease. Also, we have to take into account age of the patient, because sometimes different tumors present in different ages. So we have discussed about the characteristic of the mass. We also discussed about the clinical context, but sometimes also we've been discussing, like localization can also help us doing the differentiation. Now, of course, we have here like a mass in the apex. We're thinking all the time about like if it is possible a thrombus. The same will happen if this was a mass in the left atrial appendage. Based on the echo findings, we also have other tools like contrast echo that we use in this case that could help us differentiate the different type of masses. So we will find like a vascular mass, like in the first case, that is very suggestive of thrombus, especially we have like regional wall motion abnormalities surrounding. And if it's like a very vascular mass, this is highly suspicious of like malignancy, except from some cases, like for example, hemangioma, which is like a benign vascular mass. And when we have like patchy perfusion of the mass, this is like a classic finding of the myxoma, as you can find in the last example. That is also the typical location of a myxoma in the left atrium with stuck to the interarterial septum. We have also tools like the diagnostic echocardiographic mass score that summarize what we've been saying, all the red flags for malignancy, and help us integrate that information with a score being 5, the cutoff for malignancy suspectancy. So with this information, now what would you do next? TEE, cardiac CT, chest abdomen pelvis CT, CMR, or PET CT. This time I give options, so I'm not that bad.
I just wanted to welcome Dr. Sani here as well. So glad to have you join us.
Lost my ID, they won't let me in.
No. So go ahead and fill in this text, audience, please. Which test would you order next? And while these are coming in, I'd love to hear from the panel. It sounds like some of the key questions we have are, is this benign or malignant if it's a tumor? If it's not a tumor, what else could it be? Thrombus, Loeffler's, someone mentioned infection. I'd like to hear the panel's thoughts. What's the next best test, Dr. Agarwal, do you think?
I think for me in this patient's metastasis, like, when we think about this, zebras and horses are what we are talking about, as Dr. Amansi mentioned, and metastasis is far more common than primary tumors of the heart. So are there any foci outside the heart? Is there anything outside the heart that's happening that we have to be worried about just from the ease of future diagnosis, biopsy, anything else? Or should we be thinking about a secondary process is kind of really important in this? So CT is obviously on the differential, like something to be thinking about, which not just gives you a sense of what is happening inside the heart, but outside the heart as well. Cardiac MRI is the other tool which we obviously gravitate towards all the time just because of its superior tissue characterization characteristics. So I think either a CT or a cardiac MRI, between those two, depending upon how you want to do it, what are the clinical features you have and what your suspicion is, would be the choices. PET CT, just because of a slightly higher radiation dose, may not be the ideal first test to begin with in such sort of situation. But that's how I'm thinking in these things. The other thing that is there, just to piggyback on what Dr. Hamamsi had said, is relationship to the surrounding structures is kind of really important in this. And from that perspective, just given the location of where that mass is, looking at this relation with the LAD is going to be really important at some stage if it came down to that. And from that perspective, cardiac CT is something that I would think about quite often. The thing with cardiac MRI that is there is cardiac MRI is a fine precision tool. So it is really very good once you have identified what you want to characterize and then spend a lot of time trying to characterize it. Sometimes when you are doing just a very, very wide field of view acquisition and trying to find the mass and characterizing it, cardiac MRI is time inefficient in that situation.
I think so often these masses are surprises for us, and it's something we're really unprepared for. We do an echo for something, some symptoms, we're kind of fishy, and then, oh my goodness, we got a mass. What are we supposed to do next? I've had that feeling before. I think for some of us, we think, oh, maybe we should talk to Dr. Sani because we need some guidance on what are the right questions to ask, what's the next steps. When you get those phone calls, Dr. Sani, just from an echo with a mass, how are you advising the clinician about what to do next? What test would you order?
It's a very important question, this simply because, the incremental value of what the next test you're going to order is so important. And a lot of these patients end up getting multimodality imaging. And so really you have to get the bang for your buck almost. And so, I know I missed the initial portion, but, the echo in this case was just so obvious. This is not a consider ruling out endocarditis kind of a case. And so, for example, a TE would be such a waste of time. All said and done, and this is a patient that's going to undergo so much forthcoming testing. And so you really want to get something like, which will give you tissue characterization and anticipating a future intervention, like getting a tissue biopsy or a cardiac, interventional procedure. You want to hone in on the one test that will help you in the next step. So I think I would go with CT and MR perfectly in this. And all said and done, I know I get the pre-selected biased patients that are going towards cardio-oncology, but towards, as we go through the differential diagnosis, the red herrings are not very uncommon, all said and done, especially in younger patients presenting. And yes, of course, primary, secondary tumors are very common. But there are a lot of red herrings in the non-metastatic, non-tumor field as well, which I wouldn't say burned, but very happily burned for patients in the past that turned out to have other diagnoses other than primary and secondary tumors of the heart.
Thank you, Dr. Kasani. You're a CT PET specialist. Do you think there's a role for jumping straight to PET yet, or would you do further characterization?
Yes, I agree with Dr. Agarwal that further characterization of the lesion is a good first test. The value of PET-CT is to see if there are other lesions. If this is a metastatic lesion, you can find other primary site and other sites which could be easy to biopsy than going for the cardiac mass biopsy. So the value of PET-CT is to screen whole body to see if there are other sites or other evidence of primary neoplasm.
Thank you. So I think everyone agreed that MRI was probably the best next step, and that's what was done. Is that right, Manel?
Yes.
Okay, I'll pass it back to Dr. Agarwal then to help walk us through this MRI.
So these are your axial black blood images. They are called as black blood, obviously, because the blood looks black, and as the name says. But you can see this big mass that is there towards the LV apex, which we had seen on the echocardiogram before. It seems there is no other focus inside the heart. So that is relatively reassuring to a certain extent that you are going to focus on that particular part of the heart. These are your cine images going from the base to the apex or from the top to the bottom. And towards the very top, you're not seeing the mass on the left side, but as you start getting lower down, you start appreciating the mass. And over here again, you're seeing this, it's a relatively large mass. It seems encapsulated to a certain extent, not completely sure if it's totally encapsulated. It seems to be invading the pericardium over there, not completely free of the pericardium. There is this rim that is present. So these are what we call as SSFP images, and they can have a chemical shift artifact. So it's kind of difficult to understand if the rim is actually that big and that thick, the capsule, or it is more kind of because of the difference in tissue characterization that may be happening. But it seems to be localized over there for now.
Is the encapsulated portion, is it different from the myocardium, or is it?
It definitely has a different characteristic in the myocardium. It looks like that over here. So I think one of the things that was mentioned before was like over here. So you can look at the muscle characteristic, right? So what is present inside the mass has very, very different characteristics than what the normal LV myocardium is. That is one thing that we can say. The second thing that is there is that since there is such significant tissue difference between what that mass is and the muscle is, how much of that envelope is because of the difference between the two characteristics, and how thick is the envelope over there is tough to say on this particular sequence. We'll have more sequences further down, but as I said, over here you have these chemical shift artifacts, especially in fatty tumors, where you have to be worried about it because the envelope can appear a lot more exaggerated on this particular sequence than what it may actually be. So the envelope may be a lot thinner on these sequences.
Is the inner portion more consistent with like fat characteristics?
We can't say this on this particular sequence right now. Can you go back to that? Because that's an SSFP sequence. It's a combination of T1 and T2 weighted sequences. And it's okay if it's not there, that's fine. It's a combination of T1 and T2 weighted sequences. It helps more at that stage just with tissue, with localization. And then now at this stage, we start getting into the characterization much better. And these are more reliable because over there on that sequence, the signal that you get is a mixture of T1 and T2. So you get both parts of it, which may be there. And T1 is something that you're looking for in fat, and T2 is what you're looking in fluid or cyst. So you have both signals over there. So what you can definitely say based on that is it does not look like a normal muscle tissue characteristic. But other than that, it's kind of a bit tough to say just looking at those sequences by themselves right now. On the cine sequences. So these are your T1 weighted sequence. T1 weighted sequence are supposed to highlight your fat or very, very fibrous tissue. And what you are able to see over there is that when you have fat on this particular sequence, something really jumps out to you quite often. And what we are able to do after that is that when we are able to do something called as fat suppression on a subsequent sequence, where we are able to suppress something and see if that goes away or not. So if you look at the previous images, there is a slight hyperintensity on that particular towards the apex of that mass. And on these fat sat sequences, it gets slightly suppressed. Now, this is not the most intense sequences or the images that you will see as far as fat is concerned. So a few things can still be on the differential diagnosis, but when I'm looking at this, I'm a little bit thinking about the lines of is this kind of a fatty tumor that is present. The location of it over here, again, I think we'll have LG sequence later on, we'll be able to see slightly better. But over here, that is what I'm leaning towards. It does not look like a cyst because of what it looks like. Nothing really is obviously standing out or jumping out yet. At this stage, based on these images, it becomes more a case of exclusion rather than inclusion. As Dr. Hadley was saying, cardiac masses are something that we all expect, but we are never prepared for it. So it's something that as you go through it, you are kind of ruling out things more often than ruling in things straight off the bat. So you're looking at the cardiac MRI characteristics and you're like, okay, this does not look like this based on the sequence. This does not look like this based on that sequence. Probably the next thing will be the T2 weighted sequence. On the T2 weighted sequences, you're looking for fluid. So for fluid, if it's a big cyst or if it's, let's say it's a myxoma, because myxoma has significant watery or fluid component to that, so they will really stand out. And then when you fat suppress them, then kind of they stand out even more. So over here, based on this, you are kind of getting this slightly hyper intense or iso intense on T1 with some fat suppression, but not really a lot of cystic or fluid components so far.
So what you can exclude by now? The thrombus?
No thrombus, it does not look like a myxoma, it does not look like a cyst.
No lipoma because that's suppressed. No?
Not completely, because when you look at the T1 sequences that look at the previous one, the T1 sequences was slightly hyper intense. They were the one before this, because this is one with the fat sand. So as you scroll through this, that particular sequence over there, when you are there, see this one, you kind of has a slightly hyper intense or iso intense, and then when you have the fat sat, it gets suppressed to a certain extent. So I've not completely ruled out a fatty component of the tumor yet. I'm not saying it's a lipoma or not.
No lipoma, yeah, that's what I'm saying. No lipoma.
Correct.
Can I ask Dr. El-Mamzi a question? So, we can sit here, we can do every test under the sun. But once we've established that there's no metastatic disease, or as you said, other tissue that's easily biopsied, the only way you're going to know what it is and what to deal with is open it and take a small piece, frozen section, and then decide almost on table what to do.
Yeah.
So, once you've excluded metastatic disease, no nodes, nothing else, does the additional imaging, like you said, you need to know about the subvalvular apparatus and the mitral valve and how encapsulated this is, but is there anything else that you need before you go and say, we need to look at the tissue and find out what this is?
Yeah, I think the more information we have, the better prepared we are. And because these are rare sort of findings and every one of them is different than the other, if we were to go, especially if the point is just to do a biopsy through a median sternotomy, which is quite invasive, with the option of potentially removing this thing altogether if we thought that it warranted it, I think knowing the coronary anatomy will be important. And also getting more characterization about what this mass is will be important. So I think, again, I'm just a country surgeon, but if I go in with a thing like this, I'd like to have a PET CT just to tell me what lights up and where and how. But this is just from a layman's perspective, who's going to go in there. Is there anything else that's lighting up in the body that would explain some of this stuff? Because at the end of the day, we have to, it's a big conversation we're going to have with the patient. The patient may wake up with just a biopsy and very poor news. Patient may wake up with a biopsy and news that is somewhat reassuring. The patient may wake up with, very diminished cardiac function and cavities and all of it. So we just have to, the more prepared we are with the imaging, the better it will be.
Can I ask one quick question in this, in terms of for your preparation, vascularity, the tumor, any thoughts about that? Like, how does that affect what you are going to do or how do you prepare for that from that perspective? Because at least when we are reading these images, we pay a lot of attention to the vascularity component of that. We spend a lot of time, a lot of tissue characterization ends up happening based on that, your first pass perfusion, your LG images and everything. So any thoughts about that?
I think that would be more perhaps in terms of diagnostics than in terms of surgically. Surgically, we're more interested in the coronary perfusion to the muscle and how much we're going to have to amputate if we remove the mass, if it invades the LAD, in this case, the LAD territory. How far into the LAD does it go? Is it, is there any imaging that will allow us to see, through a coronary angiogram or otherwise, that the coronary maybe there's some separation that we can, peel out the mass without injuring the coronary, or do we have to just cut the all of these will be important considerations.
I would say surgically, if you thought this could be gynecological, you'd also have a different approach, I would think, at least from what I've read over the years.
100%, yeah. That was me actually writing.
Hypertonic saline and.
Because I've seen a lot of those on missions, yeah.
Yeah.
And it is a different story. You really have to be completely.
piggybacking off of this, are there certain findings that would lead you to conclude that there's no way you could successfully resect this, but we should still get a biopsy so that we know what type of chemotherapy or radiation would be appropriate? And if that's the case, could you save the person a median sternotomy? So if we're worth it to get to that point of deciding before you see it grossly, whether you could resect it, just based on imaging alone.
Yeah, absolutely. I think if the mass is very big, or if we think that resection will just not work because it invades too much of the heart muscle or the heart cavity, then we can do a biopsy through a small mini thoracotomy here or something less invasive. That would be much more appropriate.
We can continue the MRI images. We're not done yet, right?
Okay, this is the two sequence.
I think we looked at them. So these are your T2 sequences with some fat saturation. That's actually not that fat sat. So these are your first pass perfusion images. That is there. Obviously, any tumor with vascularity will light up. We are capturing the gadolinium as it's going through. And over here, you can see that it does have some vascularity. It's not the most vascular structure that you will see in the world. Like, you'll see some light bulbs like paragangliomas and stuff. But this has some vascularity, but again, it's not the most vascular structure in the world.
Or angiosarcomas would be super vascular.
So late gadolinium enhancement images. So again, if you saw some first pass perfusion, then you're kind of thinking that there will be some LG. The question is, what will be the pattern of LG? And over here, you can see it's heterogeneous. It's kind of not uniform. You have some components of this which are not showing any gadolinium enhancement. So it's not kind of one straightforward tissue that probably you're looking at. There will be some fibrous component to it and other things that may be there. So when we are trying to put this together and putting together the negatives and the positives, you have some first pass perfusion, you have some late gadolinium enhancement, there is some T1 hyperintensity isointensity, some suppression. So over here, it's not a very satisfying MRI finding. To be honest, we have excluded a few things, but do we have a slam dunk that these are the one or two things you should absolutely be thinking about? We don't have that in this case. What we do have is this mass, which probably is invading the pericardium to a certain extent. It's not the most well circumscribed mass that you would see. Probably some involvement of the RV apex as well, and some characteristics. Thinking about maybe a lipoma, not really a lipoma. It can be like, again, it is probably a low-grade malignancy or something along those lines. So it's not a regular bread and butter benign tumor. That is what we can say. Because nothing over here stands out, which we are like, this is what it is. Let's go ahead and do that.
In such, in such pictures, which are mixed picture, and you really cannot say slam dunk with this looks like this. Other than tumors, are they mimickers of primary or metastatic tumors such as cardiac sarcoid? Or say a Loeffler syndrome with eosinophilic infiltration of the myocardium that can mimic well-circumcised tumors like this?
Sarcoidosis, this is about a 4 centimeter mass. So I have seen granulomas, but I have not seen 4 centimeter granulomas. So I think that's probably low on the differential. Again, is there some weird characteristic that occurs? I'm not sure, but I think that would be really, really low on the differential diagnosis. Loeffler syndrome, it does not have the appearance of a Loeffler syndrome because it appears to be kind of invading into the myocardium over here. Loeffler syndrome, just the way it kind of looks, it has this subendocardial kind of a distribution that would be there. So it does not look like a characteristic Loeffler's as well over here. So it looks like more of a mass over here. Characteristic of mass, I'm not really sure. I think what we can rule out over here, just looking at this is not a very, very malignant mass, but it's not does not have the feel of a benign mass. It's not well encapsulated. It does not have that good feel to it.
Why you say it's not very malignant? Why you say that?
For the malignancy, I think you see a lot more heterogeneous LG that would be there. There would be pericardial effusion, more pericardial involvement that would be present. You're not seeing much of that right now. The mass seems to be still respecting some borders of the heart to a certain extent. I'm not saying that it's totally respecting it, because when you have these malignant masses, it kind of completely permeates, invades through stuff. You're not seeing that over here. Is this something that can be really early stage? That is still possible, but it does not feel like that just based on how the mass looks like. And the other thing that is there is, if it is relatively malignant, then some part of the tissue will probably stand out a little bit more on your characterization sequences, T1, T2, or something else. Like over here, everything is like subtle, iso, hypo, mildly hyper. So when you're looking at that, you're like, I'm not really sure what I'm dealing with over here. I think if I was to read this MRI completely blindly, there would be like 5 or 6 differential diagnoses that you would come up with. But at the end of the day, as was said before, very well said, is that sometimes you just have to go and take a piece of tissue and figure out what you're doing with, while providing the surgeons with the best possible rule outs and rules in that sort of a situation. And is there anything outside the heart that can help you? That is what I'm thinking at this stage. We have ruled out some of the benign stuff. This is not a thrombus. It does not feel like a myxoma kind of a situation. Does not feel like a lipoma. So there are a few rule outs. Is there a rule in? I'm not so sure at this stage.
And the reason why I asked you about the sarcoid is because, I mean, again, overlap syndromes happen a lot. And as you said, at the end of the day, the biopsy is such a clincher, because we had a very similar case last year with a very well circumcised cystic LV mass structure of a young individual, who then went on to Cleveland Clinic to have done presented with malignant VT. And the biopsy eventually, very similar case, ended up being cardiac sarcoid.
The state of a mass. Oh, wow.
Yeah.
Yes,
And that's what I'm saying, overlap syndromes really happen, and I understand the utility, but at the same time, the limitation of imaging, including multimodality imaging at the end of the day.
And I think this kind of just highlights the fact, at least when characterization of masses is concerned, is that we can come up with differential diagnosis unless something really strikes out. I really feel confident about it. Most of the times you'll end up with a bunch of differential diagnoses in most cardiac MRI situations.
Thanks. I think we've covered the differential pretty well. We can probably skip this question just for the sake of time. I'll hand it back to you in 1 sec, Meenal, but I'm just curious, is this the right time, Dr. Gasani, to order a PET, and what are the advantages?
So from looking at the scan, it looks like it's a low-grade malignant or still benign neoplasm. We can do PET scan to see if there are any other areas. Other areas that are easy to biopsy. So yes, this is the right time to do the PET CT scan.
And one other thing I'm taking away with this was what you mentioned, Dr. Elhamamzi, that the surgeon actually wants to see the PET scan because it can help you understand where the malignant tissue is. Is that right, in terms of surgical planning?
Yeah, and also the extent of disease, because, again, it's not a tumor in the kidney and you can just remove part or all of the kidney. This is a tumor in the heart, and so any resection has important consequences and risks. And so if there is extension, maybe it's not even operable, or maybe it's not worth operating, or maybe we can biopsy elsewhere and get a better idea. So it's, for us, it's very helpful to know what the extent of disease is. I wonder what the role of CT is here, because we haven't mentioned CT or so is it just MRI and PET CT, or PET CT includes PET CT gets that whole picture that whole body picture.
With PET CT, we do low dose CT scan. So up to 3 millimeter nodule, we will pick up on low dose CT scan. Some of the smaller nodules are not well characterized, but for general screening, PET CT should be okay for primary lung neoplasm.
Okay. No, but I meant for cardiac CTA. You won't get any of this stuff. That's what I mean. Are we skipping the cardiac CT, or what's that?
I think it's a really important point, and this will affect what happens down the road. I believe in this case, a coronary CT was not performed.
She's 26 years old, right?
49. Yeah. Right. Why don't we jump to the PET CT, since we're at that point. And I think Dr. Agarwal did a nice job covering some of the key MRI findings.
Your point was that you'd want to see the coronaries as well as the vascularity.
It's just a bit of everything. I find that the CT, for us at least, it allows us to see things. The MRI is very helpful in characterizing, but then we don't get the same granularity, spatial resolution, the definition of coronary versus tumor, and visually at least it helps us understand things better.
So we'll see the non-con CT. Let's see how much we can get from that.
Before that, I'm giving fields of information. I think this might be useful. Further investigation of the prior medical history revealed that 17 years ago, when the patient was 32, She underwent successful surgical extirpation of a low-grade liposarcoma from her thigh. No chemotherapy received, and she has been entirely well since.
How'd you like me to stop?
Extirpation. Good word.
Said extrication well.
Yeah, that's good.
Okay, everything's good.
Everything's good. If you're on remotely, you can mute your mic.
Woman that went in 10 days later and got the history out.
That's right.
So let's jump to the PET CT, please.
So I guess like.
So I'll pass this to Dr. Kasani to walk us through.
So this is just a CT scan through the level of the carina going down. You can see that hypodense mass in the apex. This is a non-contrast enhanced CT. So far, we have not seen any other findings. This is a soft tissue window. And this is a DG PET CT scan. So this scan is done with fluorodeoxyglucose FDG, which is just the radioactive glucose. And we usually ask patient to fast for 4 to 6 hours before the scan. But we often see cardiac uptake at 4 to 6 hours, normal physiologic cardiac uptake. So for anything related to heart, whenever we are scanning patient for any cardiac pathology, either malignancy or for endocarditis or device infection, we ask patient to fast a little longer and put patient on a low carb, high protein, high fat diet for 2 days. So the patients have to be prepared in a way that their myocardial glucose uptake is suppressed. So then you can see if there is any abnormal neoplastic or infectious etiology. So here we have the FDG PET images through the left ventricle. You can scroll through these. So far, again, we have not seen anything else. Everything looks fine. No lung findings, and this is the lesion that we are seeing. As you can see in this image, the uptake is not very high. It's a little higher than blood pool, but not bright. So if you have a lung cancer, metastasis from lung cancer, angiosarcoma, they are usually much brighter than what we are seeing here. So these are the fusion images, PET and CT fusion images in 3-plane. And again, the mass itself has a low grade uptake. So I believe the SUV of this mass was 4. So either benign or low grade malignant lesion right now. That is what we can conclude. And I don't have the whole body scan, but there were no, patient had a fibroid uterus and there was uptake in one of the fibroid that was very high. So we had recommended MRI of the pelvis to further evaluate the fibroid. And it turned out to be, those were just the fibroid and uptake was probably from the degenerating fibroid. So no other findings, just this lesion, and the primary site was also clear. There was no uptake at the primary site in the left thigh.
So benign tumors can also have some FDG uptake and malignant ones can have a lower FDG uptake?
It depends on so the FDG uptake always depends on the proliferative index of the tumor. So low Ki67 tumor will have a low grade uptake, while high Ki67 tumor, highly proliferative tumor will have high grade uptake. So
What about sarcoid?
sarcoid, very high uptake. Yeah.
So it's still an overlap.
Yeah, there is still an overlap. And we don't, we are just using it's a glucose. So a lot of infectious process use glucose. Inflammatory process such as sarcoidosis will use glucose. And there is a spectrum of uptake in the tumor, low grade being a low FDG avidity and high grade being very high uptake. So the FDG PET is not tumor specific, or it's just positive in cancer. It can be positive in many things. We have many other agents now coming down the pipeline that are more cancer specific, but
How
For
do-
sarcoid, it depends on the stage of what the sarcoid is.
yeah.
Is this,
Yeah.
turning into fibrosis, or is this
Yeah.
an active growing granuloma? Anyway, sorry.
How do PET MRs work? To a non-imaging person, like you've done 1, 2, how do PET MRs work?
So the,
You can answer, Dr.
so the PET MR is just going to characterize the cardiac, MRI part will be useful where the tumor will be characterized better. But when it comes to PET, it doesn't matter whether it's PET MR or PET CT.
Great discussion. One of the things that I think is so tricky about this case is all of these different modalities seem to get us to, it's either benign or low-grade malignancy. That seems like it makes a really big difference, which of those it is. What does the panel think at this stage? Are we ready to just go and try and cut this thing out? Or what's our next step?
I would just say, open her up.
I think just from the imaging perspective, without being involved in the case, one of the things that I would have liked to see in this is a cardiac CT scan. I think a coronary CT scan would have been really helpful. Again, cardiac MRI is good, but as far as tissue planes and everything is concerned, I don't think you can beat a good cardiac CT from that perspective. And again, from planning perspective, just based on the location of this, I've seen enough number of tumors where the coronary arteries get encased, and when we are telling the surgeons or asking the surgeons to go in over there, just knowing where the big vessels are going is an important component. But after that, as far as surgical planning is concerned, that has to be by the surgeons. But I think one of the key take-home points over here, at least for us, is in imaging, we are able to come up with a differential, but quite often we are not able to give a definitive diagnosis, as was mentioned before, and that is something we need to be respectful of. And there will always be surprises. We may think of something, but then you can have the sarcoid, which is 4 centimeters that you have never even seen.
Yeah, the way I'm looking at the case right now is, especially with the medical history of that thorium height liposarcoma in the past, and everything that was described on the imaging, it makes you lean a little bit more towards this is possibly that liposarcoma that's manifested many years later because it's a low-grade tumor in the heart. If that is the case, there are two options. One is we obviously want to confirm the diagnosis, and that's a biopsy. And second, can we remove or should we remove the tumor altogether? Removing the tumor will depend a lot on the cardiac CT findings, the angiogram, all of that stuff that for us will determine, can we shelve it out with clean margins without injuring the coronary and amputating too much muscle, or does it look, and from the images, it looks like it's pretty deep into the ventricle, so removing it will remove a good chunk of the left ventricle and perhaps even some of the right ventricle. And so then it becomes, okay, well, if we think it's a liposarcoma, it's a low-grade tumor, then, let's, first things first, let's maybe just aim for a biopsy. That doesn't require median sonotomy to do it. And so I think the history is very important at this point, but the defining the cardiac anatomy in, as much detail as we can will also be very helpful, because if we think we can do a biopsy and a resection at the same time, then we'll go through the middle. Otherwise, there's no point in doing so.
Yes, Dr. Bienstock.
Just, if we're just thinking biopsy, right, and you're like, I'm not gonna resect this, obviously there's more inherent risks, right? But is there ever a role for percutaneous biopsy on the left side of the heart? Obviously there's risk of stroke, I assume. If the mass is vascular, there's risk of significant bleeding. Is there ever a role? It's obviously right-sided biopsies we do all the time. Is there ever a role for left-sided biopsies? And if you're just thinking biopsy here and you're maybe not gonna even resect this, is that an option instead of undergoing surgery? Or is the risk just too high that you're just like, it's not worth it?
I think it's a little bit different, because when you're doing the right-sided biopsy, you go from inside the heart. It's an endomyocardial biopsy. And so if there's any bleeding, it bleeds inside the heart, so it's not a problem. In this case, I don't think you'd want to do a biopsy from inside the heart, because then you can just spread the tumor very quickly everywhere. So you'd want to do it from the epicardial biopsy. You can with a needle, but the heart, this is not a redo situation. So the heart is not frozen, it will be moving. And I think it's a little bit, if the alternative is just a little mini, anterior thoracotomy under direct vision and you just get a nice core, probably safer to do it that way. If there were a large pericardial effusion, then I'd say, yes, let's just go and grab some of that fluid and see if we can identify any cells in there.
But is there ever a role to do that or no?
There's always a role for
It came-
anything.
It came up recently,
Oh,
and I was like, I don't know if there's ever a
yeah,
role
I
for
think, I
this,
think
but-
it's, why is the question. If it's my heart, please just open a little bit and do it.
Have you ever seen an LV biopsy from an interventionalist? I've never seen.
I mean, I guess maybe LA, maybe not LV.
Same thing, the
Yeah.
embolization risk is too high.
Because then the question also was sarcoid, that really affects more of the left side than the right side. And you're biopsying the right side, is there ever a time to try to clinch the diagnosis, or even myocarditis that might affect more the left side of the heart than the right side of the heart? Is there ever a role for left-sided biopsy? But, in that case, I guess there's less risk of embolization and spread. Is there ever a role for that in a non-tumor situation? I don't know. Have you ever done that?
And that's what I was gonna say, if you've ever heard of anybody giving you an LV biopsy, please let me know.
Think of the right-sided biopsies where you get back as non-diagnostic. It's the surface of whatever's there, and you're really not getting what's underneath.
Right.
Okay,
And you certainly wouldn't want to futz around on the left side doing
great questions.
Endocardial.
In a cancer.
So I know, Dr. Elhamzy, you were not personally involved in this case. It's great to get your feedback. In this case, they did not do any further coronary imaging. They decided to just go and take a look. Maybe we can jump to what the surgeon saw. I'm curious to get your feedback.
No CT either.
No contrast CT, just that non-con, yeah?
They did open biopsy, right? They opened the chest.
So they went for surgery, trying to do like a resection or a biopsy, depending on the findings. And they found that there was a multi-lobulate mass extending in multiple points through the epicardium onto the epicardial surface with obvious lipomatous tissue, which appeared consistent with liposarcoma. This mass was surprisingly extensive in the tissue of the left and the right ventricles, surrounding the apex of the heart and enveloping approximately the distal 40% of the LAD. It was obvious that excising this mass in total would be impossible, and indeed an attempt to remove the mass en bloc would likely result in profound decrease in the chamber size of both ventricles, to a degree that did not seem appropriate or safe. We instead performed the excisional biopsy of the visible surface portion of the mass, sending a specimen to the pathologist.
Now, do you know what surgical approach was used here?
They went
Sternotomy.
sternotomy because they were trying to see if it was feasible to do the resection, being aware that in case they weren't able to do resection, they will.
They went in with curative intent, not just biopsy intent. But to your point, that the CT would have helped with coronary involvement and Dr. Hamamsi's point of trying an epicardial approach for biopsy, if only biopsy was the intent. Well said.
If they had the CT, they would not have done this, right?
Yeah, I mean, again, it's the decision, I'm not aware of the case, but I think in the note, what it says, it was surprisingly extensive. I would just say it was extensive as anticipated. The imaging was suggesting that it was quite extensive. And so the concept that you were going to resect the whole mass was was an aggressive one. It's one at least that if you were contemplating, I would have wanted to get every little bit of imaging information before going in there, including coronary angiogram and a coronary and chest CTA, and just to really have a very, as clear as possible, a 3D image of what this looks like and whether there's any potential for resecting it. And imaging today really gives us a lot of these information, of these answers, I mean. And in the absence of, possibly, if we see that the mass is, as they said, 40% of the LAD or whatever, then I don't think we're going to bother the patient going through a median sternotomy. We'll just do a small thing, do what they did here. And then if this turned out to be more aggressive and we think, okay, the only option for survival is resecting, then we might do a median sternotomy. But I think there might have been a middle solution here from the surgical.
So what was the diagnosis, Minel, and what happened to the patient? I know we're running out of time.
Yes, so you can see here the pathology for the metastatic low-grade liposarcoma, and the patient, she had chemotherapy, she received high-dose liposomal doxorubicin, her last dose was January 2024. She's a asymptomatic right now, class 1, and doing her follow-up in another center, and with similar findings in cardiac imaging on the follow-up studies.
The PET never changed. Well, I guess she's lost a follow-up to us, but did the PET at least change? I mean, the mass is never going to go away, but.
In the both like cardiac MRI and chest, not like chest abdomen pelvis, the findings were similar and with no other lesions elsewhere. And I think the last PET CT was after the treatment, and it was like similar findings.
Is that the only treatment, Donna? Is liposomal doxorubicin for this particular case?
Yeah, liposarcoma is so rare, all said and down, the rare of the rarest, but no, there are several lines of treatment. I mean, there's now immunotherapy, so it all depends on what the markers are on the tumor after the biopsy. So, yeah, I mean, there's taxanes, there's Doxil, there's that.
But this is not hypermetabolic. The things that you get at tissue metabolism are not going to work that well for a tumor that doesn't multiply that much, the Ki-67.
And I'm just wondering,
These things.
and even the
The specific
penetration of
ones
the
that
treatment.
attack, the immunotherapy, something that attacks the tumor directly, maybe. But, and trying to take this out and transplant that heart, which I've seen in a zillion years past, it's not great because then you lose all the body's innate surveillance and it just grows back, particularly at margins. So left atrial one.
You kind of wonder, is this like her second malignancy, a primary liposarcoma of the heart, or